Hello, everyone. This is going to be the section, again, continuing our cardiovascular dysfunction. And this one, we're going to talk about how are we going to thin the blood. Anticoagulants. We don't want the blood to coagulate. Antiplatelets. We want to push those clotting factors down. And thrombolytic drugs means we're going to break up a thrombus or break up a potential clot. The clotting has already happened. Thrombolytic drugs are also known as fibrinolytic because we know fibrin forms clots. All right, coagulation and physiology. Let's talk about that first. Hemostasis. What is hemostasis in this region that we're talking about? It's a physiological process by which bleeding is stopped. And it occurs in two stages, which are listed here. Formation of a platelet plug and then reinforcement of the platelet plug with fibrin. Both of these processes are set in motion by blood vessel injury. And then I wanted to talk to you about what happens in the arterial system and what happens in the venous system. Arterial thrombosis, begins with adhesions of platelets to the arterial wall. It's stimulated by damage to the wall or rupture of an atherosclerotic plaque, which we will cover in class if we haven't already by the time you listen to this. Following adhesions, platelets release ADP and a substance called T as in Tom XA squared. It's attracting additional platelets to the evolving thrombus with continual platelet aggregation, and all that means is a gathering of platelets. Occlusion of the artery takes place, and then we have a lack of perfusion. So arterial thrombosis stays pretty much localized in that artery of where it starts. A venous thrombi develop at sites where blood flow is slow, where we have stagnation of blood. It initiates what we call the coagulation cascade, production of fibrin, which enmeshes red blood cells and platelets to form the thrombus. It just coagulates it so that they roll into a ball. Typical venous thrombus has a long tail that can break off and cause an embolus. These can then travel to pulmonary arteries. So venous ones travel, arterial ones, for the most part, stay put. So that's as much of the coagulation physiology I'm going to go into. Okay, now we're going to talk about heparin, parenteral anticoagulants, and heparin is the powerhouse. It is it's the one that we usually use in the hospital. It's rapid acting, administered only by injection, enhances the activity of antithrombin, a protein that inactivates two major clotting factors. It inactivates thrombin and factor XA, and here it is. It's antithrombin. Without these two, production of fibrin is reduced and clotting is suppressed. It acts in minutes. It's quick. It's IV, and look what it does. It helps us prevent pulmonary embolus, stroke evolving, massive deep vein thrombosis or DVT. Pregnancy, we can use it. We cannot use the oral ones, but heparin does not cross the placenta. Open heart surgery for renal dialysis, if they're more prone to clots during that, they will have a heparin infusion going. Universally, heparin must be checked by two nurses before giving sub-Q, pushing an IV, hanging as IV infusion, and it's also prescribed in units, always in units, not milligrams. Okay. Moving on with heparin, adverse effects is always going to be bleeding with all of these. If we give too much, they're going to bleed. And symptoms, we know signs and symptoms of bleeding is always going to be hemodynamic shock, which will always be low blood pressure, high heart rate. Bruising, because bleeding into the tissues. Petechiae is also capillaries that are breaking apart. And so they're dotted purple, red spots. Hematomas is a gathering of blood. Red-black stools, depending on where it's bleeding from in the gut. Cloudy or discolored urine and pelvic pain can be some signs of hemorrhage. Heparin-induced thrombocytopenia, meaning we have a very lack of platelets. Risk for hemorrhage if platelets are under 150,000. It's a critical level if they're under 100,000. And then, of course, there's always a hypersensitivity reactions. Antidote for heparin is protamine sulfate. We're going to give it IV or sub-Q. It works by protein positively charged group or heparin is a positively protein negatively charged group, it can neutralize the heparin chain. The lab test that we need to check as we go on serial checks all the time is called APTT. It's activated partial thromboplastin. Normal is 40 seconds at therapeutic levels. Heparin increases in the lowercase a and then PTT by a factor of 1.5 to 2 seconds, making a PTT 60 to 80 seconds. And all of this means, if you break it down, just take a minute to break it down, is that normally if they were checking our bleeding time, any of us in the room, because we're not on blood thinners, it'd be around 40 seconds. Some hospitals will say 30. Well, when you're giving a blood thinner, you want that to be longer because you don't want them to clot. You want them to bleed a little bit longer to be in that therapeutic level. So to be in a therapeutic level with heparin, we want that APTT to be at least 1.5 to 2 seconds longer, making the APTT 60 to 80 seconds. Does that make a little bit more sense? However, therapeutic, we know we always have ranges. If it's more than 80 seconds, the dosage needs to be lowered, meaning they're bleeding, they're not clotting at all, and we don't want them to have to hemorrhage. Heparin is not a single molecule. It's a mixture of long polysaccharide chains with molecular rates that range from 3,000 to 30,000. It's a 5-sugar sequence. The mechanism of action helps antithrombin inactivate clotting factors, which is, again, thrombin and factor XA suppressing formation of fibrin. Low molecular weight heparin is all given sub-Q. It's easier to use and very, very effective. These are now considered first-line therapy for prevention and treatment of DVT. 3 available in the United States, Lovenox, Fragment, and Inahep. Most common seen in hospitals today. If you're in the hospital at all, half the people in there, they're on bed rest. They will give them Lovenox because they don't want them to get deep vein thrombosis from just laying there and the blood being stagnant. Low molecular weight heparins preferentially inactivate factor XA, much less able to inactivate thrombin. Let's see. They are easier to use because they can be given using a fixed dose and don't require the PTT monitoring. They can be used at home, whereas unfractionated heparin must be given in a hospital because it's much more potent and fragile. Why the difference between low molecular weight and heparin? In order to inactivate thrombin, a heparin chain must not only contain the pentasaccharide sequence that activates antithrombin, it must also be long enough to provide a binding site for thrombin. This binding site is necessary because inactivation of thrombin requires simultaneous binding of thrombin with heparin and antithrombin. The bottom line is low molecular weight heparin chains are too short to allow for thrombin binding, and hence the low molecular weight heparins are less able to inactivate thrombin. Heparin preparations are composed of, and I just basically already said that. Heparin preparations are composed of molecules that are shorter than those found in unfractionated heparin, so they're easier. All that means is they're easier to regulate. Therapeutic use, very, very effective. And here are for some of the reasons. Prevention of DVT after surgery, especially hip and knee replacement surgeries, because, people aren't moving when you've got large joints like that, immobilized. Treatment of an already established DVT with or without a pulmonary embolus. Prevention of ischemic complications such as unstable angina and arrhythmias. Multiple traumas and acute spinal cord injuries. Adverse effects are always going to be bleeding with all of these. Immune-mediated thrombocytopenia, meaning we can induce that, so it might be like an autoimmune reaction. And the cost, this is interesting. It's more than unfractionated heparin, much more, but because they can be used at home and do not require the APTT monitoring, overall cost is lower than unfractionated heparin. Hopefully that makes sense. And then Arixtra is another low molecular weight heparin, a synthetic anticoagulant, very selective inhibition, causes selective inhibition of factor XA, has no effect on thrombin. Actually, this is not heparin, I'm sorry. Yeah, we're done with heparin. Arixtra is just low molecular weight, a synthetic anticoagulant. And it, again, has selective inhibition, and that's why they know exactly what it's going to do. It inhibits factor XA, but it has no effect on thrombin. Enhances the activity of antithrombin. Therapeutic use, and you can see there are many. Prevention of DVT following surgery, hip fracture, hip replacement, knee replacement, abdominal surgery, treatment of acute PE in conjunction with sometimes warfarin, which is Coumadin, a treatment of acute deep vein thrombosis in conjunction with warfarin or Coumadin. Coumadin blocks the absorption of vitamin K, so the body cannot make prothrombin. Takes 6 to 8 hours to work, where heparin works much, much faster. That's why they'll put it with something like this, Erixtra. Adverse effects, just like a lot of the other ones, bleeding, thrombocytopenia, and this one can actually cause spinal or epidural hematomas. Okay, now we're going to move on to a different set. This is a parenteral anticoagulants 2. Parenteral meaning it's going to be IV or sub-Q or IM. It's direct thrombin inhibitors. So these are very strong drugs, and they're also selective. They inhibit thrombin directly, just as effective as heparin. Angiomax is IV only, works independently of antithrombin, inhibits clot-bound thrombin as well as free thrombin, causes less bleeding and fewer ischemic events. Therapeutic use is to prevent clot formation, usually combined with aspirin. Mechanism of action facilitates the action of antithrombin so that the thrombin can't be produced, prevents the conversion of fibrinogen to fibrin, and prevents the activation of factor X111A. Adverse effects, headache, nausea, and back pain. And this one, just to clarify a little, inhibits thrombin directly, so it works independently of antithrombin. It inhibits that clot-bound thrombin as well as free thrombin. So I hope I made that clear. Okay, we're going to stop right here, and then I will pick up with the second one to finish off our anticoagulants. Okay, yeah, 8.